healthy heart pumps red, oxygen-rich blood, but when something goes wrong with the heart at birth, these babies can literally turn blue. Let's break down congenital heart defects for the NCLEX. So let's go over normal blood flow through the heart. So it goes through the right side of the heart to the pulmonary artery and out to the lungs where it's oxygenated. Then it comes back through the left side of the heart and up and out the aorta to perfuse the body. So for congenital heart defects, blood flow is either shunted, meaning going the wrong direction, obstructed, or mixes abnormally. So these are classified as either cyanotic or acyanotic. So depending where the defect is located, most of the blood leaving the heart is either oxygenated, like in acyanotic defects, or deoxygenated, like cyanotic defects. So the main problem with cyanotic defects is, you guessed it, cyanosis. So most of the blood leaving the heart is deoxygenated, or aka blue blood. Therefore, it causes these babies to get blue. So hypoxemia and cyanosis can kill babies fast. So cyanotic defects are more critical than acyanotic defects. So cyanotic defects are classified into defects that decrease pulmonary blood flow, like right to left shunts that bypass the lungs, like Tetralogy of Fallot, and mixed blood flow defects, like transposition of the Great Arteries, that cause mixing of deoxygenated and oxygenated blood. So to remember this, most of the cyanotic defects begin with the letter T. So when you think T, think treble. These defects include Tetralogy of Fallot, tricuspid atresia, transposition of the Great Arteries, truncus arteriosus, total anomalous pulmonary venous return, and one non-T defect, hypoplastic left heart syndrome. So we're going to focus on transposition of the Great Arteries and Tetralogy of Fallot because they're super testable on the NCLEX, so pay attention. Tetralogy of Fallot has 4 defects, hence the name TET, which means 4. So pulmonary stenosis is when that pulmonary valve gets hard and stiff. Therefore, blood cannot easily go to the lungs, and instead, that blood builds up in that right ventricle. In the right ventricle, it builds up pressure and causes right ventricular hypertrophy. Then that blood has nowhere to go except through the hole in the ventricle, or ventricular septal defect, or VSD. So that shunted blood goes to the left side of the heart and goes up and out this overriding aorta, which is an aorta malpositioned over the ventricular septal defect. Therefore, most of the blood leaving the heart never made it to the lungs to get oxygenated. So in transposition of the Great Arteries, the aorta and pulmonary artery are completely switched. So there's 2 separate circuits of blood flow, one from the left side of the heart to the lungs and back, and one from the right side of the heart to the body and back. So how do these babies even survive? Well, they can't unless there's another defect present, like a patent ductus arteriosus or ventricular septal defect. Those defects allow just enough oxygenated red blood to mix with that deoxygenated blue blood and perfuse the body. So what do these babies look like? Well, remember, they are cyanotic, and sometimes they have these cyanotic spells or hypercyanotic spells called TET spells. This is when they are exerting themselves, like with crying or eating, and that can cause increased oxygen demand and cause them to become blue. Because feeding requires so much energy and oxygen demand, it causes them to be poor feeders, and therefore they even lose weight and have growth failure. Last is polycythemia. Because they have that hypoxemia, the body is trying to compensate by increasing red blood cell production. In order to do that, though, it causes that blood to get really thick and increase the risk for clotting and stroke. So for interventions, what do we do for these clients? These clients need surgery in the first few weeks to months of life to correct the defect. For transposition of the Great Arteries, we need to give prostaglandin E1. That will help keep that ductus arteriosus open to allow mixing of blood in order to ensure survival while we're waiting for surgery. Nursing care while we're waiting for surgery focuses on managing hypercyanotic episodes and maintaining fluid balance. So managing hypercyanotic spells, we need to increase oxygenation and lung perfusion. We can do this by comforting the infant or child. Remember, this spell was probably brought on by increased exertion from crying or eating, so we need to calm them down to decrease oxygen demand. So the NCLEX may ask you, how do you position a client during a TET spell? Well, we do it knees to chest. Remember, that increases pressure on the lower extremities, therefore increasing systemic vascular resistance. that increases pressure on that left side of the heart and causes shunting back to that right side of the heart and up through the lungs to be oxygenated. Then we give 100% oxygen and morphine as prescribed because those are pulmonary vasodilators that help increase blood flow to the lungs. Next, we need to maintain fluid balance. We offer small, frequent feedings, not large feedings, because remember, that increases oxygen demand. Then we monitor eyes and nose, like daily weights and weight diapers. Remember, we need to ensure that this client is hydrated and has adequate perfusion. We need to give IV fluids as needed in order to ensure perfusion and hydration. So remember, this client has polycythemia, so they're even at increased risk for stroke. So hydration is essential. So our first NCLEX quick check, what is the best position for a client during a TET spell? Well, remember, that's that knees to chest. We need to increase that systemic vascular resistance and therefore increase blood flow to the lungs to be oxygenated. So what should the nurse administer to clients with transposition of the great arteries? Well, we need to keep that ductus arteriosus open to allow the mixing of that blood. So we need to give prostaglandin E1 to do that. Now we have acyanotic defects, where our main problem is heart failure. This is because fluid builds up within the heart and causes pressure on the ventricles and leads to strain on that heart and heart failure. These are classified by two main groups: defects that increase pulmonary blood flow, like left to right shunts, such as patent ductus arteriosus or septal defects, and we have obstructive defects, like coarctation of the aorta and pulmonary and aortic stenosis. So patent ductus arteriosus is an opening between the pulmonary artery and aorta that fails to close in the first few days of life. This is left over from fetal circulation. So this causes blood to go from the aorta to the pulmonary artery. So there is shunting from the left side of the heart to the right side of the heart. So for findings, remember this hallmark sign for the NCLEX, a continuous machinery-like murmur. Then we also see bounding pulses and a wide pulse pressure. Next, we have septal defects. Septal defects create an abnormal opening between the atrium, ASD, ventricles, VSD, or both, atrial ventricular septal defect. This is, again, where blood is shunting from that left side of the heart to the right side of the heart, where there's increased blood flow to those lungs. Then for findings, we see a heart murmur because of that abnormal opening. Now for obstructive defects, we see coarctation of the aorta, and that's when there's a narrow aorta that obstructs blood flow out of the heart. So think of this as a kinked garden hose. Close to the kink or defect, there is increased pressure. So we see bounding pulses and increased blood pressure in the upper extremities proximal to this defect. Then we see weak pulses and decreased blood pressure in the lower extremities distal from the defect. For aortic and pulmonic stenosis, there is narrowing or stiffening of the aortic and pulmonic valves, and that causes decreased cardiac output. So for findings, we see a heart murmur because blood is flowing through that narrowed valve. So what do these acyanotic clients look like? So for findings, because of these abnormal openings or stenotic valves, we see murmurs and abnormal pulses. We also see signs of heart failure, like dyspnea, fatigue, and sudden weight gain, just like we would in adults with heart failure. Then we also see signs of poor feeding because remember, they have dyspnea and fatigue, so they are not good at eating, and they have weight loss and growth failure. For interventions, we prepare for surgical and non-surgical repair as needed. Then for patent ductus arteriosus, we need to close that defect with indomethacin, a prostaglandin inhibitor. Before repair, nursing care needs to focus on maintaining fluid balance and improving cardiac output. So in order to maintain fluid balance, we need to monitor eyes and nose because remember, perfusion and hydration is essential in these clients with congenital heart defects. Then we need to improve cardiac output. We do this by decreasing stimulation. We don't want to put any more strain on that heart, so we need to cluster care and give small, frequent feedings. Something like a large feeding can really strain that heart. Then we give heart failure medications, just like we would with adults with heart failure, diuretics, and digoxin. For digoxin specifically, we monitor for hypokalemia because that can increase risk for toxicity. Then we need to assess apical pulse for 1 minute before giving digoxin because it can cause serious bradycardia. Next NCLEX quick check, clients with congenital heart defects require frequent, large feedings or small feedings. Well, remember, we don't want to give a large feeding that can increase oxygen demand and exertion on that heart, so we want to give small, frequent feedings. What blood pressure finding is typical in coarctation of the aorta? Well, think of that kinked garden hose. Remember, the pressure builds proximal to that defect, so it's higher in the upper extremities and it's lower in the lower extremities distal to the defect. Then what kind of heart sound is auscultated for patent ductus arteriosus? Remember, that's that continuous machinery-like murmur. So postoperative care, after this client has had heart surgery, we need to report signs of bleeding like increased chest tube output. So signs of that are any kind of output greater than 3 mLs per kilogram per hour for 3 hours, or greater than or equal to 5 to 10 mLs per kilogram for 1 hour. Next, we monitor for decreased cardiac output, like decreased blood pressure and decreased urine output. We also need to look for infection, like we do with any postoperative client, signs like edema or redness. Lastly, we need to keep that incision clean and dry to prevent any kind of infection. No tub baths for the first 3 days postoperatively. For our last NCLEX quick check, what should the nurse do if a client postoperative heart surgery has decreased urine output? Well, that could indicate decreased cardiac output, so we need to notify that healthcare provider right away. What should the nurse teach caregivers to do to prevent infection postoperatively? Well, we keep that incision clean and dry. No tub baths for 3 days postoperatively. Now you can master congenital heart defects on the NCLEX.